Hello everyone, welcome to GrowMed. Welcome to the session where we will discuss 5 important topics from the OBG which you must know for the upcoming January 2026 exam. So the 5 topics are the PCOS, this one's the placenta previa, okay, then Asherman syndrome, imperforate hymen and the Bartholin cyst. So we'll quickly discuss what all you must know from these topics. Okay, so if you like this video, if you find this video useful, then comment part 2 where we will discuss more uh, diseases from the OBG. So we'll have a quick recall of the other diseases also from the OBG if you really find this video useful. Okay, so let's start our discussion. PCOS, a must-know topic asked multiple times in the exam. So if at all you might have gone through the PYQs and PYTs, if you have solved the questions, the GTs, then in them while solving those MCQs, you might have definitely come across the PCOS question. So we'll look at the cause. The cause which is the main cause for the PCOS is the insulin resistance. So this is most commonly seen in the young females itself. Okay. Sometimes the patients can be presenting as amenorrhea, that is the primary amenorrhea itself. So the patients will not be gaining periods only. So proper periods are not there in PCOS, and PCOS is actually the most common disorder usually seen nowadays in the young females. So out of 3 out of 5 females are dealing with the PCOS. So the clinical features are like amenorrhea, infertility, acne and hirsutism. So what exactly happens in this PCOS is we'll look at the pathology. So because of insulin resistance, the energy, the ATP, the glucose will not be reaching to the ovary. So energy will not be reaching to ovary, so there will be no growth of the follicles. So the follicles, we know that the cycle, how it the monthly cycle, menstrual cycle, right? The follicles from the primary oocyte to secondary, then they grow on like this, and then the burst, and one mature follicle, and it bursts and it gives the ovum. So this is the pathology. What happens in this is that there, due to lack of energy, the follicles will not grow. So that's why they will be staying in the same size, and multiple follicles will be seen. So this is the USG finding of the PCOD, which is given as the necklace of pearl appearance, because you can see here multiple follicles surrounded in the periphery. Classical signs seen with this PCOS. Okay, a must know image as well. So this is the pathology, that due to lack of energy there will be no maturation of the follicle. That's why the ovulation will not happen. When the ovulation will not happen, infertility can be seen, right? Because for ovulation, ovum is a must. For fertilization, ovum is a must. When ovum only will not be there, then fertilization does not happen. So it is a leading cause for the infertility as well. Then acne and hirsutism can be seen due to excess of androgens, because ovary will be releasing a lot of estrogen, right? Multiple follicles in the sense multiple estrogen. This estrogen, excess estrogen, will be converted to the androgen, giving this acne and hirsutism. So I hope all the points related to this are clear. The pathology we have discussed, and the features, why these features occur. Then USG, multiple follicle necklace of pearl appearance, is also seen. Then the criteria used to diagnose this PCOS is the Rotterdam criteria. So simple questions can be asked that Rotterdam criteria is used for which of the following disease PCOS. If they ask the parameters of this one, then it is like anovulation, hyperandrogenism, and with or without the USG appearance. 2 of the 3 should be available. If these are there, then we consider it as a PCOS for the Rotterdam criteria. Okay, remember this one. Then the treatment, letrozole, which is the first line treatment. Then along with that, we can also give oral contraceptive pills to maintain the menses properly. Like usually these female will be complaining of amenorrhea and abnormal periods, so that's why pills, okay, contraceptive pills. Then clomiphene citrate, this is usually used for ovulation induction. Okay, remember this one, ovulation induction. Then other treatments are the spironolactone ovarian drill, and metformin. So this was a question asked in the past years, that ovarian drill is done for which of the following. What we do in this ovarian drill? We burn the excess stroma. Okay, so this is all about the PCOS, which you must remember a must know topic. Then moving on to the placenta previa, an important topic from the obstetric. So what does this mean? See here, implantation of the placenta in the lower uterine segment. So this is an important cause of antepartum hemorrhage. Remember this one. The other two causes are the placenta abruption and vasa previa. Then clinical features are the painless vaginal bleeding will be seen and fetal heart rate will be normal. These two things only will help you to be identified it as a placenta previa, because the vaginal bleeding will be painless. Okay, because there is no actually harm, like there is no abruption, I mean no wear and tear. Okay, and then fetal heart rate will be normal. It is classified into the various types. So image based questions have been asked. They can give the image of this one and they can ask which type of placenta previa it is. So let's have a look. So see here, the first image, it is called as a low lying placenta because it is almost nearer to the os, lies within 2 centimeter of the os. Then it is called as a low lying placenta. If it is partially covering, it is near, almost nearer to the os, internal os, then it is called as a marginal placenta. If it is covering the os partially, then it is called as a partial previa, and this one is the complete previa where complete obstruction is there. So the management of this complete previa is LSCS, because it is very hard to deliver the head of the baby, right? Because you can see here the obstruction present here. So management is LSCS. But in the rest 3 cases, we can give a trial of vaginal delivery, thinking that if at all it is present here or here, then when the head will be coming down, chances are there that this uterus will be pushed. So whenever the cervix opens, the chances are there that this can be pushed away and the delivery of the head can be done. So a trial of vaginal delivery is done. If possible, then we will do with normal vaginal delivery. If not, then we need to switch to the LSCS, emergency LSCS. Okay, so this is how we manage the placenta previa. Be thorough with the types, because these have been asked multiple times in the exam, the image based question. And also bleeding arises from the maternal origin. So the bleeding is from the maternal origin. Remember this one as well. Then management at a term, if there is bleed or with or without bleed, we will do the LSCS if the baby is at term. I mean, if the presentation is at the term. If at term and if it is low lying, then normal vaginal delivery is to be done. And if 32 weeks plus bleed is there, then resuscitation, bed rest and steroids are to be given. This was asked in the past years. Okay, remember this one. So this is all about the placenta previa, which you must remember. Then moving on to the other 3 important gynec diseases. Asherman syndrome, asked in the recent July 2025 exam. Okay, so Asherman syndrome means it is a most common cause of a secondary amenorrhea. Okay, then the most common cause is the vigorous curettage done for postpartum hemorrhage. So this is the HSG image, hysterosalpingography. You can see here the filling defect present. So this is the image which you can see with the HSG, which is used to diagnose as the Asherman syndrome, and management is the hysteroscopic ediciolysis. So from the Asherman syndrome, these are the 3 buzzwords which you must remember: secondary amenorrhea, vigorous curettage done. So this only will be described in the clinical case, like a female with a history of curettage for PPH now presents with amenorrhea. Now on HSG you see these finding. What is the diagnosis? So Asherman syndrome, quite easier and quite simpler to identify. Okay, then moving on to the next topic, imperforate hymen. Again a very important one. And imperforate hymen is a cause for primary amenorrhea. Okay, because what happens in this imperforate hymen is that the name itself says that the hymen is intact and there is no perforation present. I mean, like in others, the hymen will be present like this, partial covering from the other side the bleeding can occur, but in this the hymen is completely occluding the vagina, causing this periods or the menstrual blood to get accumulated here in the uterus and the vagina. Okay, so seen usually in the young females 15 to 17 years. So this only will be described in the clinical case. A female with 16 or 17 years presents with primary amenorrhea, and on examination you see there is bluish bulging present on the vagina. Sometimes image also can be given of this one. Okay, the imperforate hymen image can be given. Then cyclical abdominal pain will also be described in the clinical case. What does this mean? Cyclical abdominal pain means that the female is having menses. Because of the menses, the monthly dysmenorrhea can be seen. Okay, but these are also called as a hidden periods because it is not bleeding. The menstrual blood is getting accumulated in the uterus. Okay, then management is the cruciate incision for the imperforate hymen. So this is a PYQ. Remember this one. So this is all about the imperforate hymen, which you must remember. Then moving on to the next topic, the Bartholin cyst. It is the most common cyst of the vulva. Image based questions can be asked on the Bartholin cyst. Okay, then causes are, first one is the obstruction and second one is the gonococcus infection. Remember the causes. Then flatulence, non-tender swelling, and location, PYQ. Remember this one, the question was asked on the location of this Bartholin cyst. So anterior 2/3 and posterior 1/3 between the labia minora and the hymen, and treatment again a PYQ, marsupialization is to be done. So this is all about the Bartholin cyst, which you must remember. I hope this will be quite easier for you to remember now, and in the very less time, 5 to 10 minutes, we have discussed 5 must know topics from the OBG. So these are like quick recall videos for you, which you can watch during your break time when you're exhausted by your studies. Okay, if you want more videos like this for the other subjects as well, then please let me know in the comment box. I will be definitely posting such kind of videos, short 10-12 minutes videos which you can quickly watch, and in this period of time you can actually recall a lot of things. So this is the main motto of the short videos. So if you're new to GrowMed, subscribe to GrowMed. Please share the video with your friends who all are preparing for the FMG exam, and all the best for the exam. For this PDF and many other PDF and flashcards, you can join my Telegram channel. The link will be given in the description box. You can also join my follow me on the Instagram, where I'll be posting many reels, motivation MCQs, and motivation reels, how to study, what to study, on the study routines, everything. So thank you so much once again, and all the best.